So I'm going to be, again, welcome to everyone. I'm going to be recording it for those of you who may not be able to join us today or that have to leave early. This format is not my usual format. I want to just remind you. Typically, we would have you review the PowerPoint at home, and then you would come to class, and we would do a lot of activities. But because I thought that most people would be joining us from home, the activities will be kept to a minimum. I may be talking rather quickly, but you can upload that recording and just pause me whenever you need to. So again, this is for you. I said to somebody this morning, who's got a, that might be me. Turn off your mics, please, thanks. So, and so that's the only thing, is that feedback. And so you will find that this will work really well. You may want to review it, the audio, just on your phone. There's a phone app that you can actually upload it to and watch it on your phone, or you can just listen to the audio, however you want to do it. You may want to binge watch, one day over the holidays. So however you want to do it, I'm trying to make it as easy as possible. So today, I think that we will perhaps be going a little bit over, and I just want to remind you of that. So if you have to leave, by all means, just slip out. That's absolutely okay. Knowing that this will be archived for you to review at your own convenience. So we're going to cover kidneys, GI, so kidney issues, and then the second half will be focusing on the endocrine issues. I have floated up a PowerPoint in those files, and remind me, ladies, which is it, week 9 and week 11? I think you'll find a new PowerPoint, knowing that when you open up, you're going to see like 100 PowerPoints. Before you actually faint, a lot of those PowerPoints just have one word on them. So it's not as really bad as what you think. And you might even find that there's maybe the odd speaker note at the bottom. Don't get too, those were just my own speaker notes, but I thought, well, maybe you'll find them helpful. I don't know. If you find them confusing, because I don't put everything down, just to cue me, then you can change that. Just ignore them then and make your own notes. So on that note, I am going to go to my screen share. I'm going to share my screen. And so we're going to begin with nursing management of renal problems. And again, just sort of take it all in, get the overarching essence. If I say it's important, I would write it down because it will be important. And so today we're going to talk about nursing management with people with acute renal failure. We're going to talk about chronic kidney disease. We're going to talk about common renal and neurological diagnostic testing, urological surgical procedures and the associated nursing management, post-operative urological danger signs, and to differentiate between a urethral suprapubic nephrostomy and urethral catheters, and what are the associated nursing responsibilities with those types of tubes. And I'm not sure if anybody experienced those in clinical. Depending on your area, if you might have been on the general surgical floor, you might see that. So disorders of the urinary system can include many different disorders, and so that could be as simple as a urinary tract infection. And I say urinary tract question. That should be in, is it week 9 or week 11? Look on your week 7, at the bottom of week 7. Yes. So disorders of the urinary system. And so as I say, simple urinary tract infection, who thinks that a urinary tract infection is simple? Again, that is contributes to the morbidity and mortality of many of our older adults. Acute pyelonephritis, renal calculi, bladder cancer, prostatectomies, acute renal failure, and chronic renal failure. And that's what we're going to be focusing on today. And although there are other diseases such as cystitis, urethritis, and all of these different things, we're going to talk about the common elements, and you'll be able to extrapolate that if this is associated with a UTI, that maybe cystitis, the same sort of thing. So you can start to think about it in terms of patterns. If there is a question, please don't hesitate to put up your hand in the class. And if you are online, please don't hesitate to use the chat feature. Just if you'll see on the screen, and I hope I've activated it, the chat feature. Okay, so the urinary tract infections. So these are where you're going to find different sites of infection. So as you can see, we have the upper tract, which is sort of the kidney, the ureter up to the bladder, and then the lower tract would be considered the bladder and the urethra. And so, for a urinary tract infection, if you think about your concept map, and if you find, and I encourage you to really make concept maps. I think they're very useful, and they'll be particularly useful when you go forward into year 4, when you're on your unit. And whether that's electronic or paper-based, however you want to do it. And so, the etiology and pathophysiology of a urinary tract infection. There are many different predisposing factors to a urinary tract infection. They are quite numerous, and it can be starting with the lower tract, where it could be instrumentation. And so when I say instrumentation, I'm thinking of perhaps if one is for a cystoscopy, maybe they've had repeated catheterizations, and so that is bringing bacteria into the lower tract. Women often are more predisposed to having UTIs because of the short urethra. And so and we'll talk about that in just a moment. Other predisposing factors include any kind of upper tract type infections for whatever reason. It could be a congenital thing, but however, if they have a lot of infections, they could have scarring, and scarring will contribute to a predisposing factor for kidneys. Compression of the uterus against the urethra. So anything that's going to compress the ureter, and that could be a growing fetus, or it could be even constipation in the older adult. And that is one of the strategies to preventing UTIs, is to maintain normal bowel function. The presence of a foreign body, and again, I don't even want to go there, because if you work in Emerge, you'll see plenty of foreign bodies in various parts of the body that should not be. And even that, isn't there a reality show on called ER, or the night shift in the ER or something? Oh my gosh, just flipping through it to get the channels, it's just unbelievable, some of the things that people tend to put where it shouldn't be. Some people that have poor, so you know that the urine flows and then sort of the valve closes. Sometimes people do have that reflux, and so that will be predisposed to washing that bacteria back up the tract, when in fact it should be dropping down. People that are immune compromised, very susceptible for a multitude of reasons, but primarily because they can't ward off any infection. Perhaps they have introduced maybe bacteria from the rectal area and improper hygienic practices, and so now they've, especially for children, they've perhaps not used the tissue and cleansed themselves well enough, and now they're introducing stool into the urethra. People that have other chronic conditions, such as people that have paraplegia or quadriplegia, they're immobile and urine tends to just sludge. Anyone has a neurogenic bladder. One of the things I want you to remember is diabetes. It really contributes to people that are higher risk of developing an infection, just because the sugars, the higher sugar environment, and bacteria just thrives on sugar. So people with diabetes. And so, quite common urinary tract infections, but in certain settings such as diabetes, or in immunocompromised people, or the older adult, it is, as I said, contributes to the demise of the older adult. And that's why it's incumbent on the registered nurse to look at these, does this patient need a catheter? And I was just at Markham Stouffville Hospital doing 4th year visits, and they actually have an algorithm about the Foley catheter. Does this patient really need this fully? What was it put in for? And there's a few good reasons it's put in for, but if it doesn't meet that criteria, it comes out. And so when one particular patient went onto this medical floor, the nurses were just used to putting incontinent product on and putting in a catheter. And I said, no, the catheter needs to come out. There's no indication. Remember the Safer Healthcare Now? We've talked about it in the past, the Safer Healthcare Now. It's a patient safety initiative, part of the ISMP, Canadian Patient Safety Institute. There is a bundle referred to as CAUTI, catheter-associated urinary tract infections. So UTIs is a benchmark for all of the hospitals. They report on it. So as the RN practice, your job is to look to see, have we met all the criteria? So does this patient really need the catheter? And if we should get it out, it needs to come out. The catheters are a last resort unless in a lot of cases, and it definitely is not for nursing convenience. So I just want to put that out there. The most common bacteria is gram-negative bacteremia. Have you done your epidemiology courses yet? Is that next semester? Micro, is it micro? Next semester, and that's epidemiology, so when you study all the bacteria and stuff. We're really fighting to keep that course. We feel it's very important for nurses to know that. It's really important for RN practice, and so this is the sort of thing you'll look at. What bacteria would you commonly associate with being in the urinary tract? And so quite often it's a gram-negative bacilli like E. coli. And you think about E. coli sounds familiar. We hear about it in the news because you'll find E. coli contamination in hamburger meat where the blades have not been cleansed well enough. And remember that big health issue up in Walkerton where they were not filtering the water. People were not, they were trying as a budget saving, did not have like what they needed to, and everybody got E. coli contamination. And E. coli is very deadly. It affects the kidneys, and so people would actually die from that. So just to know that bacteremia, gram-negative bacteremia is very serious. People go into septic shock as a result, and so we need to get on that very, very early. I think I've talked about all of the different conditions that might contribute to a UTI, and basically what occurs is that there is the stasis of urine, or there's introduction of bacteria into a previously sterile area, and under the right conditions this bacteria flourishes, and so this bacteria continues to grow and grow until it back up the urethra into the kidneys and back into the generalized bloodstream, and then you end up with septicemia. And so diagnostic studies that are commonly associated with UTIs. And so first of all, urine for routine and micro. Did you call it routine R&M, routine and micro, routine analysis, urine analysis, UA, urine analysis? What did you see at the hospital? Urinalysis. And so that goes under a microscope, and they're looking for a few certain things. They check the pH, 1010 to 1020, and then, and again, don't worry about that, knowing the actual pH right now, but as RN practice, you need to know the pH. And sometimes even in the emergency department, you'll be dipping it. There's sticks that, have you seen those keto dye sticks where you dip the urine and then you hold it up and check against the different color changes, and you'll actually check the urine. And there's no reason why that's a very non-invasive assessment technique. So if you think there's something going on, you can dip it. Also, when you're actually dipping it, for the presence of nitrates, it'll say, sugar negative, because there shouldn't be any sugar in the urine, correct? The kidney should filter that, and it should not drop any sugar or ketones or bacteremia or other particles in the urine. And under so you can dip it for that, and then under the microscope you'll see the presence of nitrates, which indicates a bacteremia. You'll see white cells. And one of the hallmark features is a leukocyte esterase, which is an enzyme, which is a byproduct of white blood cell count metabolism. And so the other thing you will, and we'll talk about it a little later, you'll hear what the term referred to as casts. And essentially, it is a mold of the kidney. So this bacteria or calcium has formed in those calyces, and so that is or you can get, as I said, bacteria that is molded and then is dropped out of the kidney, and you'll see in the urine these little forms, and they're referred to as casts. And so those are abnormal findings in the urine. And so collaborative therapy and drug therapy. So first of all, the collaborative therapy, well, signs and symptoms before we go on. Signs and symptoms of a UTI would be urgency, frequency, incontinence, dysuria, and they may even experience that feeling of pressure in the suprapubic area. They may also have some hematuria in their urine, although that is a later finding, but they may have a hematuria, or the urine will look cloudy. And you're thinking cloudy, it looks like milk. And yeah, and you might even find it has an odor as well. So as the condition may improve or deteriorate, the patient may then also complain of fever and chills, having an elevated white count, and they also may experience flank pain. And in the older adult, they may present a little differently, because we know that the older adult doesn't mount the same febrile response nor the white count response, or the leukocytosis. And so you may see that leukocytes may only go up to 7,000, but in someone, an older adult that normally has a white count of 3,000, that is significant, is increased. Or the temperature may get to 37.4, 37.5, never going over 38 or 39 that you may see in a younger person. So always looking at that. I find for the older adult, it's usually those changes in sensorium. And it will be when you notice that previously that person is up and doing their morning care, and now they're a little bit more attended, they're a little bit more drowsy, they're sleepy. They may even become confused and progress into delirium. So looking for those behavior changes in the older adult. And so the collaborative care is that you're going to really, it's quick recognition. So if you think somebody is experiencing a urinary tract infection, really important to get right on it, quick, because it can deteriorate into septic shock, urosepsis very quickly. So you want to get onto that. And so identifying it, so you're going to get an order from the nurse practitioner or the physician for a urinalysis, looking for all those items that I mentioned, all those elements, white count, nitrates, leukocyte esterase, casts, maybe a bit of sugar, and also then you're going to send the urine off for culture and sensitivity. It's really hard to get a real true midstream urine. I'm sure you've gone over that in year one, that you know how to get it midstream, how to do a clean catch. So really cleansing the perineum well, getting them to void a bit, and then catching it midstream. Sometimes for me, the best way is just to help them do the cleansing, putting a glove on, and then having them on a commode chair and actually placing the commode bucket underneath, and I'm just going to use it. You start to void, and you just actually grab the specimen. I find that's the best way, because it only comes back contaminated, and you do it again 2 days later. So, and if you do send a culture for CNS, please check up those results. I can't tell you how important it is for the RN practice to actually look, is this the right antibiotic that this patient can be on? And you're thinking, well, of course, doesn't the doctor order it? Well, the doctor orders the antibiotic initially, but it may not see the cultures as quickly as you do. And so may need to get back with that culture report. The pharmacist should also have a look at it when they do rounds, but it's really incumbent on the RN to make sure that you've identified that they're on the appropriate antibiotic regimen. The other treatment, so again, the medication, in the community, the physician may even leave, because it takes so long to get a doctor's appointment, and the older adult was sitting at home, and then full-blown sepsis. And so what they ended up doing is that family doctor will say, if you get signs of a urinary tract infection, just go to your drugstore and fill up the prescription. I'll leave you a prescription. And when you feel that first time you start to feel burning, or you're starting to think you have a urinary tract infection, get on the antibiotic and make an appointment with me. But at least that antibiotic can be started early. So the different antibiotics that are used are mainly sulfa drugs, drugs such as trimethoprim or sulfamethoxazole, and nitrofurantoin. Again, those drugs haven't changed in the 40 years that I've been practicing. Old medications, but they work so well. A lot of people do develop allergies to these medications after a while, and so they may have a sulfa allergy, in which case they would go on to some other medication, perhaps Cipro or Levaquin. Those are newer generation drugs, so they may be at home on oral nitrofurantoin and then come into hospital and go on to IV Cipro. Important nursing considerations are that the patient is maintaining a good oral intake. So if you have that sludge of bacteria that has sort of permeated in that bladder, growing up, and now if the patient is drinking a lot, it flushes it all away and keeps that bacteria diluted and preventing it from growing. So good oral intake is really important, and that may even include intravenous. If you feel that patient would benefit from it, we need to advocate to get an IV to ensure a good oral intake. It may mean that the patient, and they also still talk about having cranberry juice as part of the regimen to help with increasing the fluid intake, but also sort of neutralizing the pH for the urine. We did a lot of that years ago. Now it's sort of falling out of practice. I haven't seen the evidence lately on the cranberry juice, but there's no harm as a fluid source. The other things that they do for UTIs, other than antibiotics and fluids, is that sometimes it really is burns, and the pain is so excruciating that patients don't want to void, and so that fluid, that the urine still sits in their bladder and bacteria colonizes. And so what they give the patient for that is pyridium. It's an medication. It's a urinary specific analgesic, and it neutralizes the pain, and so it's called pyridium. I just wanted you to be alert to that, because if some of your patients are on pyridium, it turns the urine a bit orange. So you may think, oh my gosh, it's bleeding, but in fact it's really more orange, and it's as a result of the pyridium. This is the patient you want to do really good counseling for, to making sure that they are drinking, that they're mobilizing, because that will also help bring the fluid down and the bacteria, prevent that stasis. If there's anything, because the bladder has some like little tuberculi or little folds in it, and so you want to make sure you flush all that out. So good oral intake, making sure that the patient's bowels are moving as well. Acute pyelonephritis. We do see that from time to time. It used to be a real problem a number of years ago, before we had sophisticated antibiotics. And so now we have such wonderful antibiotics that we don't see it as often. And so pyelonephritis is the inflammation of the renal parenchyma, or the actual, the kidneys themselves. And this is caused by, it can be bacteria or anything else, such as viruses or fungi, all of those things. Typically, I see pyelonephritis as a result of a bacteremia. It starts high in the kidney portion, so in the calyces of the kidney, and it usually stays in the inflammation. And whenever you have inflammation, there's always risk of scarring. And so oftentimes, if with pyelonephritis, it will leave a bit of scarring, and the more infections, the more scarring that will occur. And then you end up with, it can be a chronic pyelonephritis. And then it can become chronic. And this is just a picture of what those kidneys look like that have acute pyelonephritis. And you'll see how the area, it should be nice and pink and fleshy colored, almost like the inside of your mouth, but you can see how it looks dry and gray. And you can see where there's some abscess formation, so that's non-functioning kidney. Clinical manifestations. So the clinical manifestations of acute pyelonephritis can vary, as with all of the infections, depending on how severe it is. Severe infections can begin with that fatigue, that overwhelming fatigue. It can begin with becoming febrile. When you get that ache that goes right to your bones, the patient begins to get febrile. They get chills. They'll ask you, "I'm just frozen. Can I get another blanket?" And they'll start to have that chills and rigor. They also will spike a fever. They'll have that anorexia. They won't feel like eating. In fact, they may vomit. They may also complain of this characteristic flank pain, and it's really right in the kidney area, and it's that it can be quite pronounced, but again, it's quite noticeable and requires analgesic for that. Diagnostic studies include urine for CNS, and they would do, of course, a CBC. And do remember that when you're caring for any of these patients, I keep emphasizing, and I'm going to emphasize these things to you now in hopes that you remember this for year 4. We were seeing some gaps in the pre-assessments, that people were not knowing what blood work to look at. And I'm going to say we talk about that, so don't just shelve this. This is stuff you need to take forward. So when you're looking at blood work to take care of your patients in April and May, remember those 4 things that you need to, the blood work you need to look at is the CBC, the electrolytes, the renal profile, and the glucose. So those are typically, all patients will have those done. That's very, very often. However, you've got maybe 2 patients or 4 patients to get their lab, not this year, but in 4 years or 2 years. And so what you need to get that information quickly. So you're going to look at your CBC. You're going to look at your hemoglobin to ensure the patient is not anemic. Now remember that the textbook norms, you won't see those often. If they have textbook norms, I would always say, is this patient dehydrated? Because our patients are not normal. The patients you're seeing in the hospital are very sick. You're not seeing well patients at all. So you're going to see someone look at the hemoglobin to see if their hemoglobin is within a decent, anything over 100 for a male, and they even let it go down to 95 for a female. But for testing purposes, always go with the textbook. And we'll give you lab values. We would never make you memorize them right now, but for the NCLEX, you do need to know your lab values. So looking at the hemoglobin, I'm looking at my hematocrit because that is an indirect representation of my fluid balance, and I'm going to look at my hemoglobin at the same time. So my hemoglobin's low and my hematocrit's high. Dehydration. So piecing it all together. So hemoglobin, hematocrit, I want to look at my white count. Is this like right off the Richter scale at 20,000? And I'm going to look at my platelets. Does this patient have adequate platelets for clotting? So those are the information I need to get going. When your day settles down, you can go back and look at the other 20 things that come on a hemoglobin CBC. But to get going, those are the 4 things you need to look at. You're going to look at your electrolytes. In particular, your sodium, potassium. Sodium is to brain what potassium is to the heart, and you want to make sure that your values are within normal limits. Chlorides, again, that's just a derivative. That's a calculated value. So yeah, it's nice to know, but the sodium or potassium will be elevated or lower, and that will give you your electrolytes. I probably look at it, make note of it, but only just to see. That's sort of an indirect representation of the pH. So if I don't have a blood gas, I can look at that and see if that's going up. Maybe there's some other problems going on. But again, the most important thing is my sodium and potassium. I want to know what my renal profile is. Looking at and looking to see that, are they getting to the upper end of normal? If the patient has a creatinine, and we'll talk about this ad nauseum because it's really important. If the creatinine is higher, up to the upper end, you're going to say, well, it's within normal limits. It's not like a hemoglobin that's higher. That's not a good sign when the creatinine is climbing and it's at the upper end of normal. That means there's renal impairment, and you need to be very cautious about what medications you're giving. So Cipro is one that would be adjusted for that elevated, not even elevated, at the higher end of normal. I really want to emphasize, and we talked about this under pain, is NSAIDs. Please make sure that you are not giving an NSAID to a patient that has an elevated creatinine. I've shared with you that the first patient I had on CRRT or renal dialysis was a patient that we gave to, as a last resort, we gave him an indomethacin suppository, very mild like an Advil, but it was a suppository. And that was just enough to topple him to the other, and put him into renal failure. That and bypass surgery, of course. But again, just being very cautious that you need to protect whatever nephrons are functioning. And so that is a patient that you would hold any NSAIDs. I had this discussion with a nurse on the floor last week, and I said, did you realize that this patient's creatinine was elevated? And they said, well, yeah, but the doctor ordered it. I said, but you're giving it. Yeah, but the doctor wanted it. The pharmacist didn't say anything, but you're giving it. So remember that it's incumbent on the nurse, because you're actually giving the medication, that you know that this is the right dose for the right patient at the right time. And so one of the clinical instructors would tell me that, well, I just think doctor's orders are suggestions. Well, I think it's kind of, I wouldn't say that they're merely suggestions, but it gives the context that we do need to think about what we're doing. And the RN is the last fortress for patient safety. You're protecting that patient. You're the only thing between that and the patient and terrible demise. So you need to be standing guard and vigilant at all times. And there's going to be nobody there to say, did you check that creatinine? You have to know that as part of your practice. So I really want to emphasize, it is the thinking about this patient. Should I be giving this Advil to this patient right now? And so just wanted to say, so those are the things I want to look at, the urea, creatinine. Remember that creatinine and urea are in proportion to one another, a 1:20 ratio. We'll talk about that in a minute. So is my urea roughly a 1:20 ratio? If my urea is higher than my creatinine, I might be worried again about dehydration. My eyes automatically shoot to my hematocrit and my hemoglobin. Because it should be the urea is going to be a little bit lower and the 1:20 with the creatinine. But if my urea is 10 and my creatinine is like 70, I'm looking at dehydration as opposed to any other condition. And then I want to see if usually they have a glucose done. So those are things I need to get going with my patient. So when you're assessing this patient with pyelonephritis, you want to look at the white count to see if there's any elevation indicating leukocytosis. Now, have you done all about your differential? Has Otto taught to you about the differential on a white count? Is that coming next semester then? Then we won't go into it. But you can also tell, as you start to piece these things together, there is a differential on the white count, and it will give you all these values, and you look to see, is it to the right or is it to the left? And so I'll leave that little piece to Otto to explain. And so you'll see that there's an elevated white count, and these patients that are febrile, and they'll be requiring blood cultures as well. Remembering that when the blood cultures, usually the lab that comes up to do them, but in some hospitals, the nurse at the bedside does them. Remembering there's this very special protocol to obtain it because you don't want to contaminate them before they get to the lab. Collaborative care and treatment for pyelonephritis. It may in fact be that the patient is hospitalized because they are sick. Generally, this is a very sick patient with pyelonephritis. They will begin with antibiotics, and we refer to this as being a broad spectrum antibiotic. Does that make sense if I say broad spectrum? Broad spectrum antibiotic until the culture is back, and then they will switch to something that is really specific to that culture. Typically, it will be maybe, again, sulfa drugs work well for urinary tract infections, but it might be one of the fluoroquines as well. Important to maintain an adequate fluid intake, treat the fever. Again, if the kidney function is fine, you could provide an NSAID or a acetaminophen as an antipyretic, and you may need to, they may need some kind of a specific urinary tract analgesics such as pyridium. And remember, pyridium changes your urine orange. Urethritis, and again, I just remember that I'm trying to just teach common things and keep them common, the things you're going to see most often. But I really wanted to pull this up because going forward into year 3, you might go to the community. Are we good? We might, when you're going through to the community, and you may see a lot of urethritis. And as you can see, I just wanted to highlight that bacterial infection, of course, could be due to poor hygiene, trichomonas or manila infection, so a candidal infection. And I've seen people actually, that is candida, they died from candidal infections. And so it's really important that if you do identify that candidal infection, which could be that white cheesy coating with a bright red rash underneath it, either in the vaginal area, it could be in the scrotal area under the arms, or in the mouth, be sure to get onto that right away, because it can spread like crazy, so you'll want to treat that. But I wanted to bring to your attention, and not for exam purposes, but just for general knowledge, is that chlamydia is on the rise here in Durham region. And we actually have the highest rate of chlamydia in the country, which is nothing to boast about, I'm sure. Although I've been assured by Regina Elliott that that's probably because of the way we track it. Other people are not doing the same kind of tracking as we are. And so we do a really good job of tracking. And I also want to highlight that other sexually transmitted diseases can cause all of these types of infections, urethritis, as well as contracted to UTIs and into the kidneys. So I just wanted to highlight that, just in case you come across that. I just also want to talk about, we think about TB. We talked about TB quite lengthy in week 2 with referring to the lungs. I just wanted to highlight that you can get TB of the kidneys as well, and it's quite serious. So it's oftentimes a secondary lesion. So they have TB in the lungs, and it's spread down to the kidneys. And it generally won't be something you're going to see, because remember that TB, you won't see that immediately. It's sort of after a repeated exposure for a prolonged period of time. They say over 3 months. And so as you can see, that the onset of renal tuberculosis as a result of a pulmonary condition, it takes about 5 to 8 years for it to present. And again, I know we're going quite quickly through all of this content. Feel free to pause at any time at home. Unfortunately, the class folks here can't put me on pause, but do feel free to, if you need to stretch your legs, by all means. The nephrotic syndrome. And so nephrotic syndrome describes a clinical course that is associated with several different disease entities that you'll see in your practice. About 1/3 of the presentation of the patients with nephrotic syndrome have another condition such as lupus or congestive heart failure. And so they'll present with a lot of peripheral edema. They're massive amounts of peripheral edema. The patients will have proteinuria. Their kidneys are not functioning because of this nephrotic syndrome. They have damaged the kidneys, and so they're not able to filter. So proteins are quite large molecules, and the kidneys have like a very fine net. Well, when they're damaged, that net just opens up and all the protein just drops through. And so the protein falls, resulting in hypoalbuminuria. So there's less serum albumin floating around, circulating, so you have less albumin to hold the fluid in the intravascular spaces. So the kidneys are damaged. That fine net that will hold the protein in the system is now torn or non-functional, and it allows the protein to drop out into the urine. So all your protein is escaping, and nothing's in the intravascular system. So there's nothing there to hold the fluid in the intravascular system. So it seeps out into the periphery. So it's a massive amount of peripheral edema, proteinuria, as well as hypoalbuminemia. And so one other thing with nephrotic syndrome, interesting enough, is that the patient has high cholesterol. I'm not sure how that all occurs, but they do have hypercholesteremia. And so as this force, because you know all of that about the oncotic pressure and the osmotic pull and the push, well, that's not occurring, and so all of the fluid is shifting out into the periphery. And so the care for nephrotic syndrome includes just pretty much symptomatic relief. So this is the patient that you need to be very careful, first of all, of skin. this patient has their skin stretched, and I'm not kidding, it is stretched over their body. So all pressure points need to be tended to. This is a patient I would order a specialty surface. Are you familiar with when I say a specialty surface? So in the hospital, we have a mixture of really nice new beds, which have a good mattress to them. It's soft and doesn't prevent pressure. Or you have the old mattresses, those plastic things that are all cracked and they're very hard. And the patient with a nephrotic syndrome would break down very quickly. And so we need to actually do our brain and skin scale. Some hospitals do them every day. Some hospitals do them every shift. Some hospitals do them every week. So we have to do whatever the hospital policy is to do the grade and skin score, and then typically they will qualify because their potential for breakdown is so great. You would report that and get a air mattress on top of that bed. So, and those air mattresses are about $100 a day. They're quite expensive, but they do prevent the skin from breaking down. There's also specialty surfaces that are, so you have like a little mattress, like an air mattress that just blows air. You may have a device that actually alternates the air, so you have a little bit more on the right side, a little bit left on the left side, and it alternates through the body. You also get some very sophisticated ones for very sick people that you actually strap them in to these specialty surfaces, their arms and their legs, and the bed actually, the air just sort of ripples down their body. At the same time, they're rotated, and so I want them to rotate over the next hour. I want them to go up to 40 degrees, and then the next hour they would rotate back. So you set all of that on these specialty surfaces, but you have to have this brain and skin score or some other evidence to support that technology so that you can afford it. So these people, it's important to maintain their skin integrity. It's important to decrease their fluid intake, and it's always a fine balance because they're losing protein and fluids out in their urine, so it's really a fine balance of keeping them maintaining adequate fluid intake and not over drinking too much. So you have to really watch their oral intake. When we talk about people that are renal patients and watching their nutritional status, we always are watching their fluid intake and keeping it to a minimum if they're not putting it out. And often that means to help them make choices that are going to make their mouth moister. So they may order more foods that are not as dry, more mashed potatoes, a little bit of butter on it, more pudding, oranges, things that we don't really include in our intake but make their mouths moist. Good oral care because their mouths are dry. And so they also want to lower and I know that they are losing protein through their urine, so you also want to include a low to moderate amount of protein in their diet. Dietary salt restrictions. They also may go on to a diuretics. They refer to it as a loop diuretic or a potassium-sparing diuretic. So a loop diuretic works at the loop of Henle. An example of that would be Lasix. And so going forward, you may want to remember that a loop diuretic is Lasix. One of the things if you're administering a loop diuretic, do remember the first thing you want to do, as soon as you see Lasix, you want to go and check the potassium. I always try to remember, I always try to remember two things that go together because I can't remember more things than that. So whenever I see Lasix, I think potassium. So do remember that. Thiazide is another example of a potassium-sparing diuretic. It doesn't have the same, it doesn't draw the potassium out as greatly as Lasix does. However, I still want to look at my potassium and my sodium, but definitely with potassium. Definitely with Lasix, I want to check that. What else do I want to do? Any of the medications that are hard on the kidneys as well, you want to be very careful when they are having nephrotic syndrome because of the damage to the kidneys. And so you really want to minimize any of the ACE inhibitors. They can be very hard on the kidneys. So again, now sometimes because of the fine balance, they are a heart failure patient with nephrotic syndrome. You may want to you may want to ensure that they've got, make sure I'm recording here. You want to make sure that you've got both of those things covered off there. So with the heart failure patient, you need to be weighing these patients, well, with nephrotic syndrome as well, weighing these patients every day. You may want to measure their abdominal girth. I tend to find that they don't do abdominal girths anymore. To me, it's a really easy measurement. If you're doing abdominal girths to assess for ascites, and if you think their bellies are really large and increasing, just take there's lots of, I just actually took a whole bunch of tapes from IKEA, because then you can throw them on after. I have these paper tapes, and you want to measure around their umbilicus. I would put 2 marks on the abdomen, so 2 pen marks as my reference point. Because if you're measuring my waist, I want you to measure it up here. But if you're really truly measuring, it would be around the umbilicus, so that you're getting a really accurate measurement. So we always just, and you can even just leave the tape in place so that if you're doing it every so many hours. But they're now generally do a daily weight. And if you're doing a daily weight on these bed surfaces, make sure that you have zeroed the bed. A lot of our technology now will have the bed, and so before your patient is admitted, you want to zero the bed. And note what you've got on the bed when you zero it, so that would be your reference point. So it's the same as you weighing yourself. When you weigh yourself, do you weigh yourself without clothes on, or do you weigh yourself with the same clothes every day? So it's the same thing. On the bed, you'll want to have a bottom sheet, maybe a soaker pad, and a pillow. And then I would not have it, and I would make a note. That's what I've zeroed the bed with, and then you can really reflect the patient's weight. But yes, I would not, the weights won't be accurate unless the bed has been zeroed. Patients are very susceptible to infection because they're immune compromised, and so you'll really want to watch that exposure. This wouldn't be the patient you're going to have beside a patient that has a pneumonia. Just a quick overview of obstructive uropathies. And so any kind of obstruction refers to anything, oh, that's not mine. Is that mine? Oh my gosh, sorry about that. The uropathies include anything that's going to obstruct the flow of urine from the kidneys down to the bladder. And so it could be congenital or acquired. It could be the result of something to do with infection or anything such as a tumor, or it could be some kind of an organ that is prolapsed. It could be multiple reasons. And so as you can see in this diagram, you're going to see that in the pelvis of the kidneys, in the pelvis of the kidneys, it could be a tumor growth. It could be renal calculi or stones that have formed. It could be in the ureter that's being compressed due to pregnancy, or it could even be a stool. It could be narrowing of the junction, so the ureteral vesicle junction. It could be any of those causes that cause narrowing of the urine flowing to the bladder. It could be due to inflammation as well. It could be just some kind of an inflammation. Excuse me, maybe that's an alarm. And excuse me. And so then it could be anything in the bladder causing obstruction. It could be a neurogenic bladder. Neurogenic bladders tend to contract and not relax. And a big thing is around the prostate. That prostate can really cause compression. You can also have narrowing of the neck of the bladder. So there could be congenital narrowing there, and that can cause a multitude of obstructions. When we talk about calculi, it could be anywhere in the tract, and so as you can see in this kidney, and I'm referring to the figure A there, that you're seeing they have this calculus that's in there, and you can see it where it has that S. That S indicates what they refer to as a staghorn calculus. So it's that calculus that is formed in that kidney in the shape of that calyce. And what else can I say? I think that creates obstruction, and the kidney becomes hydronephrotic. Types of calculi. Oh, there's many different types of calculi depending on what they're, and I could go through and list all the names. Struvite, what is it? What is another one? Struvite. There's other ones that are made of magnesium, so it depends on what the composition is. I don't think that's important at this point, the nature of the calculi, but know that it does form as a result of that particular individual, the way they metabolize, and they're going to end up with either magnesium or calcium, creating these calculi. If your patient has a renal calculi, you will know because it is the most excruciating pain ever. And when you give them the max amount of analgesic, opioid analgesic, and they're still saying, I need it, I need something, you know it's a renal calculi. They are extremely painful. And if you can imagine a rock passing through that tiny hair-like ureter, it is very painful. And so they will be they'll be hugely in distress. They'll be panting with the pain. It is so uncomfortable. Kidney stones, the incidence is higher in the east and decreases in the west. Could be genetics, it could be dietary as well. Majority of the patients are younger adults, and the recurrence of the stones can be occurring about 50% of the patients. Interesting that it's seasonal, and I don't know if that's just because of diet. You know, you have a diet that's higher in certain foods at certain times of the year. With usually it's during the summer months that it's more common. There are other, as I mentioned, there's other predisposing factors such as metabolic and the way that people metabolize the different elements such as calcium and phosphate and magnesium, and it's just the way they metabolize that. It could be dietary, so they have a diet that's perhaps dairy-based or other, it has a very high in calcium, and that will precipitate out. Genetic, oh my goodness, pardon me. Okay, so these patients, when they precipitate out of the urine, they have these stones that can form up in the calyces, and they work their way down the kidney ureter into the bladder and then through the urethra. Once it gets to the bladder, the pain is not as intense because the ureters are very fine, and it's almost like a colic as the body tries to eject that. The body doesn't like anything foreign, so it's like a crampy, way more than it's a colic. It's like a intermittent type intense pain. And so these are the patients, they are excruciating pain. And so what we do is we try to manage their pain, and we also want to make sure they don't end up getting a urinary tract infection as a result of it. We also want to push fluids to help pass that stone. And also the other thing we do is we strain for it. That will be something important to remember, that we strain for the urine. And I'm sure you've seen those strainers on the units. They're like a white strainer, white cap, cone cap, white cone, and it has a white liner or filament. And so every time the patient voids, we just dump their urine through that to try and get one of these to see if they're passing their stone. And once they pass it, we are going to send that stone off for analysis. They can identify what's causing it, and then we can be more targeted in the treatment. So diagnostic tests would be, of course, a urinalysis. Often it's going to be bloodied because of the trauma of that stone coming down the ureter. For culture, they may do an intravenous pyelogram, so injecting a bit of dye to see if there is an obstruction, intravenous pyelogram, or an IVP. They may do a retrograde pyelogram, which means that they're going to inject dye that's going to flush back from the bladder and go upwards. Again, just looking to see where it's obstructed. They may do an abdominal ultrasound or a cystoscopy. So they can put the scope up into the bladder and push it up to the ureter to see if it's maybe caught at the junction. And I just brought along this picture here. That's what some of those stones look like. They almost look like coral that you might see. They're very tiny. You could almost miss it. And sometimes there's blood clots in the urine. So look at these pictures. The stones are quite unique in their form. Treatment for kidney stones, well, again, I think pain management is the first and foremost. It is excruciating. And so the treatment would include lithotripsy. Oftentimes, they'll wait and see if the patient can't pass the stone, so they'll push fluids, they'll provide pain medication, and then maybe after 3 or 4 days, they're not passing that stone. It's still there, and it can cause obstruction and compress the kidneys. So they'll want to go in ahead and do this lithotripsy. Lithotripsy has been around for a long time now, where they actually, it's just like a high-frequency ultrasound, which will break up the stone. It smashes it up. There's no incision. It's just through they do it in the X-ray department or radiology, where it's a sound wave that will actually break it up, and then they can pass these little particles through the urine. Hopefully they don't have to go in and surgically retrieve it, because that is a big surgery. Any kind of surgery that cuts into the flank area, because the kidney is almost underneath the rib cage, it's very painful, and it can impede the diaphragm. So surgery is really the last approach, and looking for nutritional therapy after that. And so really trying to have the patient include foods in their diet that are lower in those elements that cause kidney stones. So they want to prevent the formation of stones. So again, looking at foods that will be high in calcium. That could be milk or dairy products or spinach or broccoli or anything like that. Anything that's going to cause oxalate formation, and so that could be the different types of fish or spinach, that sort of thing. So a lot of nutrition and diet therapy for people that have kidney stones. And once they have them, they seem to repeat, as I mentioned, up to 50%. Just wanted to touch a little bit about cancer, because we do have some of our folks in the class that are on oncology, and I just wanted to talk a little bit about kidney cancer and bladder cancer. And this is a picture. You can see the tumor growth in the kidney. This is renal cell carcinoma, and I have to say, one of the last patient that I remember sending to the OR for a nephrectomy as a result of cancer actually bled out on the table and died, because it's very serious. These operations are very serious. And who would have thought a simple surgery like that, the patient would die? It was quite tragic. So clinical manifestations, the incidence of kidney cancer is rising, and predominantly more in males than females. I just wanted to mention that kidney cancer, and I want to say that a couple of reasons we're seeing more kidney cancer and more bladder cancer, and one of the reasons is that we're seeing adenocarcinoma, which is typically found in the lungs. We're seeing that more in the kidney and bladders now, and it's because of cigarette smoking. And it's not only just that person who's smoking, it's that secondhand smoke as well that's contributing to the risk factors. Other risk factors are obesity and exposure to asbestos and other types of elements, gasoline, stuff like that. Firemen are at higher risk of bladder cancer because of the fumes and exhaust that they have inhaled over their career. Now, we don't see it as much now. I see the firefighters now are very protected, and they have a paramedic on guard that says, you can't go back in that burning fire. You've had your 20 minutes, you have to come out now, and somebody else goes in. So very much more regulated. But years ago, such as our neighbor who has bladder cancer, he just rushed into the fire and, of course, inhaled all of those gases from that polyester sofas and that sort of thing. So higher risk of cancer, of kidney cancer at the present time. The diagnostic tests that are performed is really a good history and physical, identifying the risk factors associated with that. Intravenous pyelogram. They may go in and do a cystoscopy and try and do a biopsy through that cystoscopy. once they do the cystoscopy or the biopsy, they do what they refer to as cytology. Have you talked about that at all in any of your courses? The cytology specimens, analyzing it that at the cellular level, and they stain it to see, are the cells normal, are they abnormal, and can we identify any rapidly growing type cells that would indicate cancer. So if you haven't talked about cytology, I expect you'll be doing it in one of your courses, whether it's a micro, maybe it's with auto, but you will, so sending off samples for cytology. Can I just remind everyone that when you are sending off your specimens, that they are well labeled? I know that we've taken patients to the OR, got a sample, and then couldn't find it. So really important that when they do retrieve the sample, that you identify it with the patient's name and then put it somewhere safe. Bladder cancer, and I just wanted to highlight, as you can see in this diagram, where bladder cancer, the bladder is a big vesicle, a big balloon, that you're going to see it sort of like growing into the wall of the bladder, but also it's going to extend and infringe on the capacity of the bladder. Clinical manifestations, and because it's not, pain isn't usually associated with one of the earlier signs, it's generally just weight loss, fatigue, weakness, anemia is often associated with it. And then as it becomes more advanced, you're going to see hematuria. They may even develop some flank pain. What else do I want to mention here? And again, for bladder cancer, they're going to do an IVP. They may do a CT scan or an MRI. Once they discover that tumor, as you know, they have to go on and stage that tumor. You know, that's that tumor staging. So the tumor is the nodes. Is it spread to local nodes? Is it metastasized? So that you get a sense of how aggressive this cancer is. Bladder cancer management, so surgical, and so they may just go in and locally excise the area, or they may be as aggressive as removing the whole bladder, depending on what the nature of the cancer is. They might do a radical cystectomy, and I've seen that, where they actually just scoop out everything and take the bladder, and then they bring the bladder, the ureters, up to the surface. They go through the terminal ileum, and they call it an ileoconduit. So they take the bowel and they feed the ureters into it, and it's really urine coming through that. It's not stool, it is urine, because and then they manage with their bowels. They would use chemotherapy, and there's a great interest now into that targeted chemotherapy. I'm not sure that we have that available to us in Canada, but people I know are going to the States for it. That Rob Ford, the mayor of Toronto, he had that targeted. So they take the tumor, and we know that, like for bladder cancer, for instance, we would maybe give adriamycin, and that's been around for 40 years. I remember mixing adriamycin myself, and the pressure was so great that it would hit the ceiling. In ours, because we were using 50cc syringes, and nowadays that can cause cancer, and so nobody can prepare that except for a special pharmacist under Lavender Hoodflow. I think I did that for years. Anyways, so adriamycin is a medication that's given for all bladder cancer as well as lung cancers and other types of cancer. What people want now is that they want to take the type of cancer they've got, adenocarcinoma, renal cell cancer. They want chemo that's going to actually stop that type of cancer. Very expensive. Rob Ford was experimental. I think it cost him hundreds of thousands of dollars. So, but that's where we're going, and that's what people are asking for. So it may be systemic chemotherapy as well. Nursing management with urinary retention and incontinence. Urinary incontinence retention. I just don't want to belabor the point, but just know that this is a problem, I should say, a situation that nurses can really impact, that we can really intervene with helping patients become continent. And please do not be that type of nurse that can't wait to get the Foley in, gets the Attends on. And I can't tell you the number of times I've heard the nurses say to the patient, oh, just pee in your Attends. They don't even say that. They say pee in your diaper. I find that highly offensive. Highly offensive. So and as caring practitioners, we don't do that. And so it's really important that for patients that have urinary incontinence and retention, that we look at what is causing the problem. Really delving into doing a very thorough history and physical of why this is occurring. And looking to see if there is this patient have some kind of obstruction? Are they unable to cleanse themselves? What is the issue at hand here? And then they're going to do a voiding log. You want to keep about a 7-day log to see how patients are actually managing. Are they able to void? And then sort of help them troubleshoot. You want to find out what is the issue that's causing them to be incontinent or to retain urine. A lot of times it's very simple things, and so for urinary incontinence, it may be just getting them to do Kegel exercises. So that tightening of the floor of the pelvis, getting them to hold it, and then relax. Just doing those Kegel exercises, and you'll be learning a lot about that next semester as you help the laboring mothers with those Kegel exercises. But getting them to tighten that up and then relax and doing those quite routinely to help that muscle floor strength. They also want to see when are they having it? Is it when in times of stress? Is it when they cough or sneeze? And a lot of women, especially after after childbirth, it does happen. So factors that might contribute to urinary incontinence, as I said, could be infection. It could be some kind of a neurological disorder, but it's really important to start with those basic steps, finding out exactly what is the issue, thorough assessment, thorough examination. Maybe they do have a candidal infection and they just didn't report it. So really doing a thorough assessment and looking at that voiding log. If the patient is having retention, they're doing a post-residual void, PVR. You'll see that, better go down into a PVR. Has anyone used the bladder scanner at the hospital? Yeah, it's pretty cool, eh? Now I used to say that we needed to do percussion because we could do that with percussion, but we have the sophistication of the technology, we need to use it. But so get your hands on that and practice with that. It's really quite non-invasive, very easy to use. You have to follow the right steps to get the important data. I saw a patient that had a residual, a post-steroid residual of 800. You had 900. What were you thinking? Quite distended. So again, anything over 300 is considered high, and you should really get a Foley catheter for an in and out. You don't want that bladder to overstretch because it's just like a balloon. Once you blow it right up, it's going to be stretched out and you're not going to get the tone. So you don't want the bladder to get much more than 300 mils in it at a time. And so the comment here is that when you have such a large PVR, post-void residual, that you're going to do a Foley in and out, but you don't want to take out all of that urine at the same time. And I'm going to suggest that you look to the literature and what does the evidence say. That was very old thinking, that you would release it because you're thinking 1,000, the patient become hypovolemic. Well, this is fluid out of their system already, and even in terms of the space, the 1,000, if so, I've got 1,000 in my bladder. Think of a milk bag. I've got that sitting in my bladder. It's compressing the vessels around. It really doesn't. It's not the current evidence. So you don't want to have that patient stretch their bladder. Point being, you want to get in there and intervene when the post-void residual is around 300. So don't let it get to that grade. What else I want to mention about that? Again, you want to make sure the patient is drinking well, and that they're not having anything that could be perceived as irritating the bladder per se. And they say that coffee and alcohol could be perceived as being bladder irritants. So remove that from their diet. Continue to void every 2 to 3 hours while awake. Getting into that habit. Apparently smoking has a high link with incontinence, so stopping smoking or smoking cessation. Preventing constipation is really huge, so making sure the patient's bowels are moving and making sure that there is no continued urinary retention. That might mean a stool softener right from the get-go. And as you know, a lot of our patients, we're giving them all kinds of narcotics, we're changing their diet, so they're at high risk for constipation. Urinary retention is a medical emergency that requires prompt recognition of bladder drainage. What happens with this, and you'll see this often with older adult with the prostate, they're trying to, they're trying to void, and they can't, they think they'll go to the bathroom, but then they get really tense and everything tenses up and then they can't void. So they think, well, I'm just going to sit here, and because of embarrassment or such as, they're not going to go to the emerge, they're going to sit at home. So their bladder now has 900 mils in it. And then as that 900 mils continues, it refluxes back up the ureters to the kidneys, and it actually will compress the kidneys and impair that function. So this patient really needs to be catheterized quite quickly. And so just a couple of things I wanted to go over with you, because you may see this in the clinical setting. Instrumentation, and I think that you're all very familiar with the Foley catheter. Typically, we're going to put the smallest Foley in that you can. Could you also remember to secure the Foley with some kind of securement device, whether that's a stat lock? Some hospitals are, they're wealthy, they have all these devices. Some hospitals where I've worked have all been poor, so we just use tape. But making sure that you've got the Foley secured to the thigh, and not over hairy legs either, but make sure it's secure, because you don't want that to be falling, and that balloon will pull down into the ureter for one thing, but also you don't want to have it moving back and forth. So what we do is we secure it on the thigh, and not to pull it because you don't want any problem with the skin, but just so that you have a nice little bit of a loop, or a little bit of tension, a little bit of looseness in it, not really tight, so that won't move back and forth, and it's not likely to get caught. So I just wanted to highlight that the figure A is a simple Foley catheter using the smallest size. If there's a lot of blood in the urine or a lot of clots, you're going to need a larger size, and that might mean an 18. If you have a large catheter, such as an 18, expect bladder spasms. So remember I told you the body doesn't like anything foreign. It's going to eject that Foley catheter as best it can, and then urine's going to spurt out around the Foley. If I could also remind everyone to follow the hospital policy in terms of pericare or Foley catheter care, and it often requires BID or TID cleansing. So at Lakeridge, it may mean that you have to wash around that catheter with soap and water twice a day to prevent infection. B is another type of a catheter. It's has a different shape at the end. That is used for a suprapubic prostatectomy, or into the abdominal wall. They'll put that type of Foley catheter. It's a bit bigger so that it can help to drain that bladder. A Malacot, again, just a different end. Acute catheter, so figure E has got a little bit of hook on the end. Typically, nurses may or may not be able to put those in at your hospital. Typically, you can put in a Foley, not a problem. By the time you're using a Acute tip, the doctor, the urologist, needs to come in, and so it has a little bit of a hook at the end to go past that prostate. I also want to draw your attention to a three-way Foley catheter. This is just, for some reason, make note of it. A three-way Foley catheter, as you can see, has 3 ports. One is the balloon port, to blow up that balloon. The middle port is to drain the urine away. That third arm is to add irrigation, which is plugged in, and it's usually normal saline irrigation that is run through to cleanse the bladder and remove any of the clots that might be forming. We've run that very, very fast. Now, 2 hospitals that I know do not measure the urine because you're running it so quickly. I still want to know that they're making urine, because you're just getting irrigation back. I want to make sure I'm getting urine back as well. Instrumentation, again, I just want to always highlight that, being very conscientious. I just want to make sure that when you do your Foley catheterization that you will do pericure prior to inserting it, especially for males, and really pull back the foreskin and making sure that it's all cleansed, because there can be bacteria growing there. And I do believe that there was someone who had what they refer to as phimosis, but I need to get the catheter in. I did the best catheter care I could get, but I do believe there was still some bacteria around it, and I just pushed that in when I catheterized. So again, being really cautious, because you do not want to contaminate anything on your tray and introduce any kind of bacteria. Okay, we talked about that. We talked a little bit about renal and urethral surgery. And again, just a quick preoperative management will be the same as any other kind of care, in that you're going to be making sure that they are familiar with the procedure, that they can demonstrate deep breathing, coughing, and leg exercises, that they're aware that they're going to have a Foley catheter, that they're going to have a dressing, and hopefully they've got PCA, because it can be quite uncomfortable. Post-operatively, you're going to be monitoring very closely the urinary output, most importantly, the respiratory status. And again, put a star beside it, I don't know why, but because of the high incision, whether it's the left or the right, the high incision, the patients tend not to breathe as deep because it's so painful. And so we really need to make sure they're well medicated and that they're deep breathing and coughing and ambulating. And don't forget, ambulating, sitting the patient up at the side of the bed will bring that diaphragm down. It drops the diaphragm, enlarges thorax so they can really take some deep breaths. They're now looking at laparoscopic nephrectomy, so doing it in such a small keyhole type surgery. And we know with there are benefits and disadvantages to doing laparoscopic surgery. The surgeon doesn't have the full view of the field, and so if there's any kind of abnormalities, they may miss that. I did have somebody, one of my friend had a cholecystectomy through the laparoscopic approach, and he was a little bit heavier set guy, and they took out the gallbladder, but only took out half of the gallbladder and left the half with the stones in, because they couldn't visualize the field, and bile leaked down into his hip joint. So again, there is the advantages that it's a smaller incision, deep breathing, coughing, less respiratory compromise, but at the same time, there's not that same visualization. We talked a little bit about this urinary diversion, and I just want to bring your attention to number B, which is where they take the terminal portion of the ileum and bring that to the surface, and they attach, as you can see in the diagram, the 2 ureters to the bowel, and that becomes an ileoconduit. An ileoconduit will be the exact same as any other kind of stoma, so it needs to be assessed every shift. You want to be looking for any kind of bleeding. You want to see that the stoma is nice and pink, and you might even see that term, what's the term that people have? Dusky. Stoma should not be dusky. They should be pink and moist and look glistening. If that looked a bit purplish or bluish, that's an abnormal finding which was urgently reportable. That is a red flag, because that patient needs to get back to the OR. That stoma is symmetrical, as you can see, so there's not, it's a circumferential type circle, there's no skin breakdown. It protrudes a little bit. These should be actually protruding above the stomach or the muscle about 1.5 centimeters. And this will be easy for the patient to manage. So you can put an appliance on that quite nicely and get a nice snug fit with that. They also do these various procedures. This is a pocket or pouch. And so this is sort of where the ureters are all put into that little pouch, and then you get this little pouch, and then you will be able to be continent. It holds the urine for a bit longer, as opposed to having the bag on the outside. The bag is really on the inside, and then they can put in a little catheter and empty that. As you can see in this particular picture, this one is a very difficult stoma to manage. Although you can see those red rings around it, they've had an appliance on, but you can see that because of the folds in their skin, the skin is irritated below it, say just below 6 o'clock there. It's red. That's raw when they've got those little blisters. You'll never be able to put appliance on that, and it will be difficult to manage. So we do have products that we use, but it would be really difficult. The best thing is to prevent any of that. Okay, I've completed the presentation on renal challenges that you may experience in the clinical environment. We've talked about infections that you might be exposed to in the clinical environment, urinary tract infections, bladder infections, kidney infections. So think about it in those 3 discrete areas. We've talked about different types of surgery that you may see with a patient experiencing a renal health challenge, and different types of management. And so I'm going to proceed to the acute and chronic kidney injury. I'm not going to take a break. For those of you folks who need to have a break, by all means. If you feel that you need to have other obligations, I understand that. Please, you're free to leave. And I will record this. But it is so nice to see faces here, I must admit. So anyways, it's entirely up to you what your pleasure is. I'm going to move on to renal failure. And so for this, and thank you for muting. I just want to make sure that I'm still recording. Sure, it says it somewhere I'm recording. Oh, just one moment here while I check. I think there's some messages here that I missed. Is everybody able to hear? Turn audio on your mic. Okay, great. Now, how do we pause? Okay, good. I hope everybody figured that out. So, see, it's working. It's working. That's perfect. All right. Okay, I think everything is going well. Just want to make sure that we are recording, but even if it is not recording, yeah, it looks like it's recording, I would do this all again so that we could make sure that you have a recorded copy. And so moving along now to our acute and kid injury, yes? Oh. Thank you very much. Okay, so now let's just get out of this. Okay, I wonder if it's when I go to change. Let me just take this one out. Screen share. Okay, so now I have to resume my screen share mode, my screen share function. Thank you for your patience and actually helping me work through all these challenges. Oh, there it is. I was looking for it. It's typically. Okay, have we got it there? I think we do. Yeah, I think we got it. Great, thank you. Okay, so we're going to go on to acute and chronic kidney injury, and I just want to identify that this has such a huge burden of disability for our patients, and so and for our health and for our country as well. We're finding that a lot of patients, and especially our Aboriginal communities up north, it's kidney disease and kidney dysfunction are huge. So it's really an important topic that we do need to talk about. I will go through some of the, is it not posted, this PowerPoint? Yes. Okay, good. And so the reason why I'm going through this is because in year 3, I've had students go to community and they've actually done dialysis, home dialysis. So I want you to have some of the underpinnings of that. And that sort of helped me to direct what we're going to talk about right now. So acute kidney damage, it can be classified into 3 sort of classifications: pre-renal, intrarenal, and post-renal. And so pre-renal are any of those conditions that prevent the full volume of blood or cardiac output from reaching the kidneys. So that could be anything such as kidney hypovolemia. So perhaps the patient has been vomiting and now they're becoming dehydrated. So it could be anything that contributes to dehydration and hypovolemia. It could be because they're hemorrhaging. And so they've lost a large amount of blood volume, and so they're now less circulating volume, which is less volume getting to the kidneys. It could be because of GI loss, vomiting, diarrhea, and some of our patients, that especially our older adults, are very susceptible to small volume losses. And so with the diarrhea conditions such as C. difficile, we can really see some severe fluid loss and dehydration. It's hard to believe that excessive diuresis, but sometimes when we have patients with heart failure, we can be quite aggressive with diuresing. So we might order Lasix 80 milligrams BID, and they put out 2 liters in a day. That could perhaps precipitate dehydration and then pre-renal dysfunction. Myocardial infarction or cardiogenic shock are also very prominent causes for pre-renal failure. Anything that prevents the blood to getting to the kidneys. Any kind of condition that causes, and we'll talk about it in our final week when we talk about shock, but when we have like an anaphylaxis situation where we have that massive vasodilation and all the fluid leaks out in the periphery. So again, fluid sitting out in the periphery, it's not in the intravascular space. It could be renal vein thrombosis. So the patient had been in atrial fib, has a little tiny blood clot that's now gathered steam as it's traveling the body and is lodged into the renal artery. So all of those conditions will prevent cardiac output or blood flow to the kidney. And if you don't have blood flow going to the kidney, that will then create a situation that will impede function and contribute to renal failure. Intrarenal causes of kidney failure or kidney injury would be anything that's going to damage the actual calyces, the nephrons, anything that's going to be destructive to the kidney itself. And so one of the common causes of that is prolonged renal ischemia. So a patient that might have been in a code situation, so patients that we have resuscitated successfully, we've got a heartbeat back, neurological function's not there. Oftentimes that would not perfuse the kidneys during that. And in fact, in some situations, that is the sacrifice. We'll sacrifice the kidneys in order to perfuse the organs that we need to. And we can do that quite deliberately. So anything that's going to cause ischemia of the actual calyces, anything that's going to be nephrotoxic. Some of the medications we give, Lasix very hard on the kidneys, enoxaparin, Cipro, there's a whole long list of medications that are cleared through the kidneys that are very harsh. One of the antibiotics, gentamicin, any of those sorts of medications are very harsh on the kidneys. X-ray dye, remember we've talked about that before. Patients that have any kind of kidney issues, we really need to pre-treat them before they have any CT scan, or alert the team that maybe you want to do that CT scan without contrast. So any kind of radioactive dye used in the X-ray, so the contrast they use for a CT scan, so they inject anything they would inject, we want to be alert to that. That's the part of the role of the nurse to say, this kidney function is just marginal. You may want to not do it with radiopaque dye. Or you may want to pre-treat them. And so we talked about that, how we give them a fluid bolus in advance, and we use other medications such as Mucomist to actually protect the kidney. So any kind of radio contrast dye, any kind of crush injury, so patients have been, squished between 2 cars, that sort of a crush injury can cause that damage to the nephrons. Any kind of continuous and sustained hypertension, and I'm really high hypertension can damage the nephrons. Any kind of infections can damage those nephrons. Calculi, as we talked about, they can damage those nephrons as well. As that rock formation is forming in that little tiny kidney, it can actually compress the functioning of the calyce. And then finally, you can have post-renal causes of it. So any kind of benign prostatic hypertrophy from an enlarged prostate, cancer, tumor, any kind of neuromuscular disorders, strictures. Again, I bring that neck of the bladder that is very, very tight, or there could be some problem at the where the ureters attach to the bladder, or where they exit at the neck of the bladder. You can have strictures there. Any kind of trauma can contribute to post-renal. So something that is blocking the urine from escaping from the bladder. And so that can cause acute renal failure. And so acute renal injury, I just make this a bit bigger so I can see what I want to say here. So acute renal injury, and we look at, I sort of highlight that you can have acute renal disease or chronic renal disease. And so the two, again, acute renal injury occurs suddenly. So that's the patient's had a cardiac arrest, or they've been in the OR and the patient's been had a problem with the blood pressure and it's been too low for that patient. I want to highlight too that you know that a normal blood pressure is 100 to 130 systolic, but let's just say a blood pressure was 90, that may not be, or even 100, that may not be that low. However, if the patient's norm is 180, that may very well be too low for that patient to perfuse the kidneys, and they'll be symptomatic. So acute kidney injury can occur suddenly. Most common cause is acute tubular necrosis, usually due to one of those conditions, as I mentioned. Can be nephrotoxic medications, it can be obstructions from a variety of reasons. And so how are you going to diagnose it? Well, you're going to see a decreased urinary output. You're also going to see an elevation in the urea and creatinine. It is potentially reversible, but the longer that you wait, or the longer that the condition goes untreated, the less chance that you're going to get full function. So you really want to move forward with a plan to protect the kidneys. High mortality of 60%. About 60% of our patients that have acute, excuse me, 1 second, I'm not sure. Pardon me. And so the mortality with ATN is very high. What does it? Please remove this window away from. Oh, I don't want that. Oh, they don't want that. Gosh, all these things. It stopped the sharing. I should stop it now? I think we're good. Do you think I hope we can still see it. Okay, good point. Yes, you're recording. Oh, now I can't type here. Okay, thanks everyone. And so just to highlight that the mortality is very high, and we have to be really diligent on this, because you're going to see patients that perhaps on your units where the blood pressure is a bit trending down. You need to get on top of that. I had this is all confidential, right? Out in virtual land and in the class. I had just doing a visit, and a pressure was 70 on 40. Yeah. I'm glad to see that reaction. You do never leave that, because this patient could end up, while you may be able to increase the blood pressure, you get the patient bolus the blood pressure up, that patient may have already sustained damage to those kidneys. So really important that you need to keep a normal blood pressure for that patient to perfuse those kidneys. So always be thinking at the back of your mind, how is this affecting those kidneys? Primary cause of death is from infection, but also because of the renal failure. But what happens is that they're not able to excrete their urine. They can't, in acute tubular necrosis, they're not able to excrete urine. They have fluid, they become fluid overloaded. The fluid actually seeps back up in the lungs, they die of pneumonia. Chronic kidney disease, on the other hand, occurs over many years, often caused by diabetic neuropathy. We see a lot. We'll talk about that when we talk about endocrine. And so they have minimal kidney function, that their GFR, so the glomerular filtration rate, is less than 60. And so they do have a little bit, you need to preserve that. It is progressive. and it is irreversible. So you want to preserve maintain that blood pressure, as you want to prevent any kind of toxic chemicals on their kidneys, and in the end, this patient will perhaps need dialysis. Cause of this, cause of death is cardiovascular disease, so that not only do they develop heart failure and heart problems, they die of an MI. So just to give you a nice glimpse of what like a damaged kidney looks like, you can see those dark areas in the center, which are, and the kidneys tissue around it is very pale and swollen. Acute tubular necrosis is the primary cause of acute kidney injury and the most common cause of acute kidney injury or failure. Typically, as we said, the result of ischemia. So there's not enough blood flow to the through the renal artery to the kidneys, and the kidneys are not being perfused. As a result of some kind of a or it could be nephrotoxins. Typically, that is a medication or some kind of pharmacological agent, as we mentioned, antibiotic like Cipro, enoxaparin, radiopeg dye, but it also could be some infectious agents as well, like E. coli and sepsis. It starts very insidiously in the basement membrane of the kidney, of the nephron, and then it takes out each nephron as it becomes more and more damaged and non-functional until the entire kidney is taken over. What else did I want to mention about that? I think that's all. With acute kidney injury, and you want to think about this. I want to go over it slowly because I think this will be important and to remember for not only this course, but going forward to year 4 for. So with acute kidney injury, there's 3 different phases that the patient goes through. And so as they're in the early phases or the initiation phase, you're going to see the creatinine going up. And remember that the urea and creatinine are a 1:20 ratio, that you're going to see a creatinine, urea going up, and the creatinine goes up. So if you see a creatinine of 20, or a urea of 20 and a creatinine of 200 to 300. Patients that are dialysis dependent, you'll see creatinines of 500 and 600. So don't be surprised, especially for the people that are on the oncology unit that do see the dialysis patients. If the creatinine it's the trend that you're looking at. So it's characterized by an elevation in your urea and creatinine, and you're going to see a dwindling urinary output. Typically, a urinary output is 1 ml per kilo per hour, and you're going to see a real drop in that. And you may not see 30 mils in 24 hours. And so as the urine starts to drop off, they enter into like an oliguric anuric phase. And so you're going to see the urinary output be dropped to well less than 400 mils in 24 hours. So less than 400 mils. Again, thinking about 1 mil per kilo or 30 mils per hour is a typical normal for an adult. And so they're going to drop their urinary output. And during that time, that it's very incumbent on the nurse to minimize their fluid intake from whatever source it's coming from. Really important that you need to monitor for urinary output, but also monitor their intake very, very carefully. So during this, when they refer to as the maintenance phase or the anuric, oliguric phase, the urinary output is very low, less than 400 mils an hour. That can last for weeks. They can last for weeks that way. And then once they go through the anuric phase, then they will go forward, and they actually have they go into this phase where they of urinary output where they make a lot of urine. So they make a lot of urine, but it's not good urine. So after the 2 weeks of really not putting out any urine, and the urine that they are putting out it looks really cruddy, for lack of better words. It's going to be maybe milky and white because the kidneys aren't functioning, the calyces aren't functioning, and so it's going to look really gross, and you're going to have decreased urinary output, decreased pH, and the patient will experience other fluid and electrolyte abnormalities. So then after about 2 weeks, as the kidneys start to recover, they're still not fully functional, and they put out lots and lots of urine, And it can be up to 2 liters a day, even greater than 2 liters a day. And so you really need to be monitoring that this patient does not become dehydrated. So as they've gone through that dwindling urinary output, no urinary output for days to weeks, then they enter in this where they make this massive amount of urine, or they have this oliguric phase that can last for a couple of weeks as well. Like it can last for a couple of weeks to a month, where they have this massive amount of urine, but it's not good urine. And then they start to show slow signs of recovery. This can take up to 12 months to recover. And they may never recover full function, but it will be improved. So I just wanted to identify that looking at the change in the urinary output through the different phases, that when the patient is in this anuric phase, that they're going to have fluid volume excess, so they're going to have a lot of fluid in their system that they can't excrete. So it's really important that you're auscultating the chest, listening for any accumulation of breath sounds. Metabolic acidosis. And when we started a patient on dialysis, it was metabolic acidosis with hyperkalemia. Those were the two things that would get you to the top of the dialysis list. Because the patient can't sustain that way. Remember that if you have hyperkalemia, that effect on the cardiac status, remember that high potassium can create all kinds of terrible arrhythmias. And so this patient will experience that. Plus the fact, remember that we talked about metabolic acidosis, and remember the heart does not like an acidotic environment. So this patient would get to dialysis. And also with all of this, the patient may experience a sodium imbalance. Hematological disorders. So remember that erythropoietin is made in the kidneys, and as the kidneys are not functioning, there's no erythropoietin manufactured, and they may become anemic. So may need an injection or an exogenous supply of erythropoietin. There's a calcium deficit and a phosphate excess. So calcium deficit would be, again, concerning because we use it for muscle contraction, we use it for heart function, as well as for blood clotting. So watching all of those parameters. Waste product accumulation. So you have all of these nitrogenous wastes accumulating in your bloodstream, and this patient is going to become confused. As the patient goes through the recovery phase, as they go through the recovery phase, the BUN and creatinine and the glomerular filtration rate start to trend towards normal. And again, that's the word I'm looking for, is during this phase, the patient goes into the diuretic phase. That's the word I'm looking for. So you have your anuric, then you go into the diuretic phase. This diuretic phase is that sort of that period that lasts from weeks to months as the kidneys are trying to recover. With this diuretic phase, the patient is, as I said, putting out 2 liters, over 2 liters a day. I'm sure you're concerned that this patient's going to become quickly dehydrated. You're thinking that this is a kidney patient, I don't want to give them fluid. However, they're in the diuretic phase and they are now going to become dehydrated if you do not replace the fluids that they have lost. So it is a really fine balance. But just to remember that these nephrons are not working and they're not filtering the waste product. So you've got tons of urine, but this urine is not good urine. This is not waste, this is just fluid, and the body still has the nitrogenous waste floating around, and they're not filtrating as they should be. This is where you're going to see a patient when you have a large amount of urinary output. This may be a patient's going to have a hypokalemia. Now, we don't know to the degree of function, so they still may be hyperkalemic, but when you see a large volume of urine, the question you ask yourself, what is the potassium? Is this patient hypokalemic because they've lost a lot in this urine, or because the nephrons are not working and so they're hyperkalemic? And you're going to also have hyponatremia. And then as the weeks go by, you're going to see this all start to normalize. But again, as I mentioned, it may take up to a year for this patient to really get full use of their kidneys again. Older adults. Older adults are more susceptible, of course, and that's the demise. So we'd have cardiovascular surgeons coming in and say, this is a great 80-year-old. And we'd say under our breath, yeah, but he has 80-year-old kidneys. And so while you could repair the heart and put some really big vessels and really improve the perfusion of the heart, you're still lacking that the kidneys are still going to take a hit. On bypass patients, we would put them onto the bypass machine. And what the perfusionist, so a perfusionist was often an RN or an RT, or a respiratory therapist with specialized training, and so they're responsible for the extracorporeal circuitry of the blood floating outside the body, well, because they have to stop the heart, right? But what I wanted you to understand is that because the heart's not functioning, they don't have that pulsatile flow. The kidneys are used to that systole, diastole, systole, diastole. And so they've lost that pulsatile flow. And so that's when their kidneys take a hit. So we had to be really careful of that. What else I want to mention? The aged is also, it takes them longer to compensate for any changes. And so they're very susceptible to dehydration as well as other to medications as well. So just to keep that in the back of your mind, I just want to quickly talk about chronic kidney disease. So as we talked about, it's a progressive irreversible, again, acute kidney disease, reversible, chronic, not reversible, loss of kidney function. It's when the glomerular filtration rate drops less than 60 mils per kilo per minute, so don't worry about that. What else I want to mention? And there's various stages. I don't think it's important that you understand various stages, because once we get to chronic kidney failure, chronic kidney disease, I just want to identify that it does, these patients experience deep psychological conditions, anxiety. They often might go on to dialysis, and so they're tied to this machine. They can't go to Christmas because they have to go to dialysis, and so they're really essentially tied to dialysis. So they experience a lot of anxiety associated with that, with good reason. So it requires a lot of reassurance and a lot of flexibility in nursing care. So if you want to go to your families on Sunday, why don't we see if we can't trade your dialysis run time with somebody else. Really try to make it flexible as their lives are tethered to the dialysis machine. They experience depression. That could be due to the nitrogenous wastes that are still floating around, or experienced because of the losses. Neurological, they're often very fatigued because of they are often dialyzed every 2 to 3 days. So they may have fatigue, experience headache, because of the electrolyte disbalance, sleep disturbances. They may even get an encephalopathy. Oh, am I still good? I hope. Cardiovascular, they may experience hypertension because of the extra fluid floating around. They have heart failure because of the extra fluid, as well as they experience greater risk of coronary artery disease. Pericarditis. Interesting, and we talked about that. So pericarditis is fluid accumulation between the pericardial sacs. Remember, there's about 30 mils of fluid in there, and because of especially uremia or nephrotic syndrome, and waste in that they experience this rubbing or this friction, and you get a pericarditis. Peripheral vascular disease, they experience pulmonary edema. Integumentary, they end up with this pruritus. They end up, because of the waste products circulating around, they end up with this like white frost. They call it uremic frost, actually, a white snowy frost over their skin, and it's very, very itchy. So if you can picture this patient that has this, they're very cachechic, they have very thin little bones and wrists, their skin is very tissue paper because the chronicity of their disease. They have these little patches because their platelets aren't functioning as well, and they have this uremic frost that's very, very itchy. So I want to just, and their skin is dry and scaly, and they'll have scabs everywhere, and you're going to put a blood pressure cuff on and dislodge the scab, and they're going to bleed like crazy. So just I think you're getting that picture of what this patient with chronic kidney disease looks like. as their renal function deteriorates, they lose all of the excretory function of the kidneys, the regulatory function. As you know, the angiotensin originates in the kidneys, so they lose that, and all the endocrine function. So all of the aldosterone and all of those mechanisms are lost as well. And so it really impairs all parts of the body, and ending up with elevated BUN and creatinine. The patient has abnormal electrolytes. They end up with, as I said, this pruritus. It's just, they're so itchy, and it actually affects their cognition and mentation. It also affects the carbohydrate metabolism as well. So that's why they're so catching. Electrolyte imbalances, and I just want to highlight, we've talked about potassium and sodium. Calcium we've talked about, magnesium. Magnesium, again, is really important in preventing lethal cardiac arrhythmia. So I just wanted to point that out. I think we've already highlighted that some of the clinical manifestations, you're going to have anemia because of the lack of erythropoietin, bleeding tendencies because the calcium is altered, and so the platelets start sticking, they may get infection. We've talked about cardiac dysrhythmias because of hypokalemia, also hypomagnesemia. So we've talked about. The respiratory system, because they're not excreting fluid, it's all sitting in their lungs, they go into pulmonary edema. We've talked about their mentation, and because of their alteration, they're often very weak, and the lack of calcium. So again, just to help illustrate the pathophysiology. So you go into kidney failure, decreased glomerular filtration rate. Again, kidneys aren't functioning, so they're not going to be able to filter it out quite as nicely. You're going to have decreased phosphate excretion because it's not exchanging, so phosphate's going to increase in the blood. And you're going to have decreased activation of vitamin D because you need calcium and phosphate to actually activate vitamin D in the gut. So you're going to have impaired calcium absorption from the gut. Decreased calcium is going to be available. Bone demineralization, you're going to have elevated calcium, so hypercalcemia and hypophosphatemia. And I'll talk about some tests that we would do with high calcium just very shortly. Clinical manifestations, I think we've already talked about that. And diagnostic tests. Again, the usual test, the CBC, electrolytes, I want to assess all of those. Urea, creatinine, I want to assess those as well. And I want to see what my sugars are, get a random blood sugar. Collaborative management, drug therapy will be targeting at hyperkalemia. And so some of the medication that I have administered for hyperkalemia would be K-Exolate. I'm not sure if anybody has heard of K-Exolate. K-Exolate is an ion resin. And the first time you give it, you'll never forget it. It is given either through an NG tube, because oftentimes the patients can't swallow it, so we're going to have to do an NG tube, or it's going to be given as an enema. And so we give it as an enema. It's in a sorbitol base, or something that's going to make it be expelled, because what you want to do is you want to bind up that potassium and then excrete it. So a K-Exolate enema is a cation-ion exchanger, I guess. So you want to treat that hyperkalemia. You want to make sure the patient doesn't become too hypertensive, because that's just further stressing out the heart. You want to prevent any kind of chronic kidney disease and mineral and bone disorder, as the calcium is leached out of the bone. You want to monitor the cholesterol levels and any complications from any of those. So treatment and nutrition, we already talked a little about it. So it would be protein restriction, but we don't want to restrict all of the protein, because we talked about how we need some protein to act as that oncotic pull. So we need to just have a protein restriction, sodium and fluid restriction, and we talked about that. Potassium restriction. We know what salt if you're using a salt substitute, you'll want to know what is the base of that salt. So really looking at where all the sources of potassium coming from. One other thing, if I can just back up for one moment, the treatment of hyperkalemia, as I mentioned, was that K-exhalate enema. The other treatment in a very more emergent situation, so if my potassium is 6, we may give the patient Calculi. Sometimes we don't have time or the patient's not able to retain the enema. What we might do is give a cocktail. And so the cocktail will be sodium bicarbonate and glucose. And so that will help to drive the potassium into the cell until you actually, and you give a bit of insulin with that because you don't want the patient getting hyperglycemic. So we give a little cocktail to push the potassium into the cell, just a temporary measure. We also may give some calcium gluconate to protect the myocardium until we get that potassium down to a decent level. I just wanted to quickly go over peritoneal dialysis because, again, you may be in the community doing peritoneal dialysis. Peritoneal dialysis is done through using the omentum as a membrane. So when you think about somebody on dialysis, they have all these filters. I'll show you a couple of samples. Those filters they filter like the kidneys would. Well, in a patient with peritoneal dialysis, which is done at home or in the hospital, but done at home, they have the omentum as that membrane, that semipermeable membrane to shift the fluid across. And so they put in this catheter, and oftentimes now they're doing it, we used to do always in the OR, and now we're not, we've done the bedside. So I just wanted to highlight that they put in this catheter, and you can see where they have the omentum there as part of the apron that will be the semipermeable membrane. So basically what you do with this peritoneal dialysis is that you'll have an order for how often they're to be dialyzed. So maybe it's 4 times a day, depending on what their creatinine is. You would warm the solution. You want to have it warm because if you give it cold, they're going to go into shock. So you want to warm the solution to body temperature. Then you're going to hang it. So they'll give you all the parameters. The dialysate is the solution that we refer to as the bag. So we're going to hang up the dialysate with the solution is particular to this patient, what they need. So you hang up the dialysate that's been warmed. You're going to release the clamp, and you're going to indwell that 3 liters, 2 liters, whatever the order is. And so it's going to stay, generally the patient will be lying down. So then it stays, it's going to, because of the oncotic pressure in the solution, it's going to draw out all the waste products, and it binds with that using the omentum. And then the doctor will say the dwell time will be 10 minutes, and then you release it. So you're going to dwell for 10 minutes, and then you're going to unclamp it and put the bag on the floor, as you see, and drain out all that solution, and out comes all the waste products with it. Pretty cool, eh? So as you can see, this is what a peritoneal dialysis catheter looks like. Well healed, and again, this is this patient's lifeline, so we always protect them, making sure there's no pull on them. You're going to get an order for the dialysis solution and the cycles, which is how many times a day you want to do it, and the dialysis system. As I said, patients are doing it at home. As you can see in this particular diagram, they have this thing actually that warms it as it's going in. You don't want to give it cold because it can cause quite a spasm. And so this is an automated dialysis cycler, which can be used for the patient who's sleeping. So it'll indwell automatically and then allow it to draw out. So the technology is so great these days. There is continuous dialysis, so that they'll continue to be dialyzed. So always big complications with dialysis. So just to be good to know that you want to look for infection, of course. This is the patient's lifeline. I've seen where that omentum has gotten infected, like a peritonitis. Ooh, what a mess. What a mess. Pus oozing out of that. Patient actually ended up getting septic. So again, peritonitis, as you can see, abdominal pain. If you are indwelling too quickly or allowing solution to fall in, infuse too quickly, it can cause some cramping. So just be aware of that. Outflow problems. So maybe you've got a kink in your tubing. You haven't released the clamp quite fully, and it's not exiting as quickly as it should. hernias, lower back problems, bleeding. That's always a big concern, is bleeding from the site. Pulmonary complications, remember that you're putting this fluid in. Where's my diagram here? So just remember that you're putting fluid in, and as you can see, there's your liver and your diaphragm. So as you're putting 3 liters into this belly, yeah, so there's your diaphragm up there, and so the fluid may actually irritate the diaphragm. So it's really important that you are aware of that, and that you get that if the patient is complaining of pulmonary problems, that you are addressing that. And if the patient has any surgery in that area, then they are not eligible for peritoneal dialysis. Protein loss, carbohydrate, and lipid metabolism issues. But protein loss, again, that would be related to the dialysate solution. Effectiveness of an adaptation to the chronic peritoneal dialysis. Again, we treat the family. I have to just in a brief moment here. I was called upon. At one point we were moving from our house in the country to our house in town, and so we had a trailer at this small little trailer park. And about 2 in the morning, I got a knock on the door. Can you come and see my husband? He's a dialysis patient, and he's not doing well. Can you come and see him? And of course, I'm going to come and sit and be with somebody. And when I went into this little trailer, it was like a hospital. They had everything going. They had a dialysis. It was hemodialysis, I believe. There was a dialysis machine. There was an automatic blood pressure cuff. There was thermometers. There was dialysate solution. There was warming. There was catheter trays. Oh my gosh, I thought I stepped into a well-stocked hospital. And he was septic. And so the only thing I did was just call for 911. There was nothing we were going to do. So again, you will often be called upon, and with these patients at home now with all of these devices. Hemodialysis, again, want to highlight this only because you may come across this in your clinical practice, and I just want to alert you that you may see different types of fistulas or cannulations. And again, these are lifelines, so you want to be really careful and protect those at all costs. So there's different ways to for hemodialysis. Hemodialysis is when they're going to shuttle about a liter of blood a minute out of the body through this dialyzer or this membrane, and then shuttle it back into the body. And so there's 2 different ways they do it. They're going to have either a fistula or a looped graft. I've been most familiar with the lower photograph, this looped graft. So you will see this in your patients, so never use that arm for anything. You wouldn't do a blood pressure on somebody who had a shunt, just like if they had a mastectomy or anything like that. You would never use that arm. If you put a blood pressure cuff on it, you could damage it, and that could be their lifeline. What I would encourage you to do is actually just take your fingers and gently touch it. When we talk about a thrill, in health assessment, touching that, you'll feel this tiny vibration underneath it, and that is a thrill. So if you get the opportunity, it's like a little cat purring. You'll feel that thrill. And so what they're doing, they also, and I'll show you, they create this this access site, so this loop, and they will actually put a needle, cannulate, as you can see here, they're going to cannulate from the artery and then back in the vein. So that's how the shunt sort of works. And they're needles. They just stick those needles, just like large bore needles, 3 times a week. So you can imagine the discomfort that they go through. This is creating that fistula. Vascular access. So a lot of times our patients, especially in the ICU, require dialysis for whatever reason. And so they'll actually put in some kind of a central line catheter, a double lumen catheter. And you may see this as a subclavian or an jugular, right, IJ. So you'll see this double port. And as you see, one port is for venous access, one side port is for arterial access, and the diagram will show that to you. But I do want to highlight again, this catheter is their lifeline. You do not infuse anything through that catheter. You do not take any blood from that catheter. It's only the dialysis nurses. They're often heparinized with a large dose of heparin, like 10,000 units. So you do not touch it. We protect it at all costs, check the site, etc., but we do not touch it. The dialysis nurse will strictly be the one responsible for it. And that's really what I want to emphasize with this part. And as you can see, this patient has a subclavian, and so the blood will be coming out of the red port, going through the dialysis machine and being delivered back in, or come out the blue port and go in the red port as the blood is being shunted for over 3 hours. This is sort of what the machine would look like, the hemodialysis machine, and again, this is kind of technology that that nurses will do at the bedside. You'll become quite experienced with it, with the dialysis unit, and so we always need to make sure that the blood will not clot outside the body, because as soon as it comes out, the blood will clot. So we need to make sure the patient has enough of anticoagulant. Now, they say heparin there. We now use other medications such as citrate to anticoagulate the blood, because we know heparin takes a long time to neutralize. So again, just look at this for overarching, nothing that would be something you need to know at this point. Settings for dialysis. Again, dialysis units can be at home, like at a center, a freestanding center. We have a couple in our local area. It's a great job. I know people that work in the dialysis unit, they love it. They're dialyzing these patients. They get to know their patients. They get to know the families. It's very technical, because as you are monitoring the patients, they may have a hypotensive episode. And just the other thing too is, if your patient is going for dialysis, check and see if they should get their medications, because if you're giving your 8 o'clock medications and then they go for dialysis at 10 o'clock, all those medications will be dialyzed out. So it may be better to give them after the dialysis run. Home units, pretty neat. And this is what the actual dialyzer, that's that membrane. So in the peritoneal dialysis, we use the momentum as that membrane, that semi-permeable membrane. This is the dialysis unit, the dialyzer. And so, let me just pull this back. So complications, hypotension is one of the biggest ones. And what do we do when a patient drops their blood pressure? We give them fluid. So it's sort of you're running around to catch your tail. So the important point is that you want to try and prevent that drop in blood pressure. And so I always start I would do it a little bit differently so I could prevent that drop in blood pressure. Because if you think of it, we're taking off a liter of blood, like boom, right like that. And so no wonder they become hypotensive. So again, doing that a bit slower initially until you get all the blood dialyzed. So hypotension is a big thing. Like muscle cramps, because of the electrolytes shifting, loss of blood, they can bleed at the site, but also you've just taken a liter of blood right off into your dialyzer. Infections, sepsis, those are the main complications. Continuous renal replacement therapy. So for patients that are very ill in the ICU, they would never tolerate a 3-hour dialysis run. And so what they do is they do continuous. So they actually take it off very slowly and give it back very slowly. And they may not even take off any fluid. Some of my patients were so sick I couldn't take off any fluid. And that would be up to the discretion of the nurse. I had to monitor them because I'm there all the time, so I might only take off the waste products. I couldn't take off any fluid. And that would just be a matter of me setting the dialysis machine up. But the patients are too sick. So this is continuous renal replacement therapy. Again, this is quite often seen with a patient with other chronicity, and diabetes is one of the highlights. So you're dealing with a patient that also can become hypoglycemic or hyperglycemic quite quickly. And of course, in the older adult, they're very much more subject to minor changes. So that is the section I wanted to cover today for the genital urinary system. We covered acute and chronic renal failure. We've covered the highlights of the signs and symptoms of acute renal failure. What are the risk factors contributing to acute renal failure? We've defined pre-renal, intrarenal, and post-renal failure, and what is the nursing role in managing those. We've talked about the phases of acute renal failure. And knowing what to expect as they become anuric, and then when they go into then they have that last for about 2 weeks, then they can go into the diuretic phase. And so thinking about the shifts of fluids, that will be really important to think about, that when they're in the anuric phase, fluid is all sitting in their lungs. When they're in the diuretic phase, they're getting dehydrated. So just keep those thoughts in mind, and how you would manage that patient. And then we talked about chronic renal failure and how it affects every single body system, and how you can really mitigate some of the complications associated with chronic renal failure. So I'm going to stop the video recording right there. And what I'm going to do is I'm going to give a little pause. I'm reading the body language here, and some of our folks are getting a little bit weary, but I would like to do a quick overview of the endocrine, and whether people stay here for that, that's great. If you don't, if you want to do it on recording, that's fine. If you want to download the app and read it on the bus, that's fine too. Whatever is good for you, knowing that I will deliver this content in whatever way is going to be most helpful to you. So I'm going to stop recording.